Thanks, Rami. Thanks, Mohammed. So, my take today is to speak to you on why TKA fail. When do you say a TKA is going to fail? When it fails to give you a painless, mobile, and a stable joint, and most of the times we cannot salvage this procedure without doing a revision. So, this is a time when the knee is going to fail. The timing of failure is important because the cause and the mechanism of failure is decided based on the timing of failure. Early failure is when the knees fail less than 5 years, and late failure is when it's more than 5 years. The causes, the mechanism is completely different for both. When it's early, it's most probably due to instability. We just heard about the session on infection. It could be because of the patellofemoral problems and arthrofibrosis, which causes a stiff knee. So, and some of these can be associated with some technical errors. Late is when, the poly is a problem. We have polyethylene wear leading to osteolysis and septic loosening. So one should be able to distinguish between these two causes. The matter of concern is when the knees fail before 5 years, because a knee is technically, theoretically supposed to last at least 15 years or more. But when it starts failing in the 5 years, that is your huge concern. And the knees which fail after 5 years, the etiology is different and you need to tackle them in a different way. The first 5 years, you have to look for the technical errors which may have led to your failure, especially gap imbalance, mediolateral imbalance or balancing in flexion extension, component malposition, improper sizing. You may sometimes raise the joint line, poor cementing technique, and we heard about that in the morning. Also poor patellofemoral tracking, and if you are overstuffing the joint. So all these are potential risks for either instability or there may be malalignment which can potentially cause the knee to fail. We have to be aware of three main sources from where actually this failure starts. Sometimes it can be patient related. Patients may have comorbidities. Some patients are more prone for infections. Some patients are previously operated, so they are again having issues. Some patients are having compensation issues, psychological issues, so you've got to be aware. The second is the implant which you use. Now we've seen that certain implants have been withdrawn within 2 years, within 3 years. We know that an uncemented total knee replacement was withdrawn. And what happens when those were put in? I think those are the ones which fail, and those are related to the implant. And then the most importantly is the surgeon related, the technical errors which I just alluded to. If you see this meta-analysis from Saleh, he shows that majority of the reasons are related to instability, infection, malalignment, and implant loosening due to a technical error. I think these are the important causes which you need to see. We'll just go through a few of the important ones. Instability is because of the poor balance you get. It may be a flexion instability or extension instability. A lot has been talked about the mid-flexion instability, and these are the patients who typically are balanced in full extension and at 90 degrees, but in the range from 30 to 60 degrees, they are having signs of instability. And typically the patient will complain that he's finding it difficult to ascend from a sitting chair, will find in descending chairs and descending steps. These are the patients you've got to watch for. Extension instability may be symmetric or asymmetric depending on how much resection you've done, how much the joint line is elevated. And at times when there is a mismatch, you've got to go upper on the femoral size. And I think these are the issues which you see. And if this is the picture which you get, immediate post-op, it's not really a good idea. The patients will complain of giving way. Patients will say that the knee doesn't feel right. It cannot take weight. They have to continue with some support. And these are the patients you've got to then really work them up for instability. Infection is something, which majority of the times, 95% is caught in the perioperative period. And I think following a strict aseptic techniques, and yesterday we heard Bharat talk about the OR requirement on sterilization. I think that's very important, and we can potentially avoid all these perioperative infections. Some patients are more prone for infection, and whenever we are dealing with rheumatoids, diabetics, obese patients, patients who have compromised immunity, then these are the patients you've got to counsel them. They have a higher risk of getting infection, and these patients need to be told so. Another reason which is important is the patellofemoral problems, and many a times we ignore this. If the patella is not resected well, then we may get some subluxation. We've seen fractures and also extensor mechanism disruptions, which can be a horrendous complication. I think it's important to avoid putting the femoral component in internal rotation, and we have seen this error happening, and suppose this happens, then your patella is not going to track well, and if you realize this later on, it becomes too late, and at times it becomes very difficult to also recognize it intra-op, because most of the times you've completed your steps. You also then need to understand what are the bailout things. Sometimes you can lateralize the femoral component. You should have more patellar coverage, and I think these are the steps which you need to follow. But if there is a rotation of the femoral component, then it's a difficult situation. The second mechanism of failure is malalignment, and we've heard about malalignment last evening. We talked about the various types of malalignment. And I think whether a malalignment is primarily responsible for failure, because we talked about the kinematic alignment where you say that you put the tibia in slight varus, and which potentially is a source of malalignment. I think malalignment as a cause is definitely debatable, but end of the day, I still feel that you have to recreate the mechanical axis in the Indian situation, and we should not go for any other techniques. It is because of the improper cuts, so you have to see that you are completely neutral, and your femoral and the proximal tibial cut and distal femoral cut at right angles to the mechanical axis, and that's the principle which I would strongly recommend to follow. Most of these patients will get pain, stiffness, and then you've got to work them up. Osteolysis, which is caused because of the polywear, these are the causes which will come after 5 years, and you've got to really beware. After 10 years, this will be a mechanism of failure, and that's the natural process which is going to occur. But if it occurs between 5 to 10 years, then that's a problem. Aseptic loosening is again could be because of mechanical reasons, or then could be as a process of osteolysis. Periprosthetic fractures are seen. If they are because of falls, then one can understand, but if it is because of notching, and this is a technical error, and if you notch, then that is a potential cause of a fracture. RSD is something which we see, and these are difficult patients to deal with. Sometimes the lumbar sympathetic blocks can be helpful. So these are the various symptoms of the failure patients. We've got to investigate them well. We've heard during the day how to investigate them. X-rays will help us to tell us, and a good X-ray every 3 months, 4 months will pick up the radiolucencies, polywear, component breakage, and tell us a lot more information on the mechanism of failure. So I would like to say that it is important to identify the cause of failure. Patients undergoing revision without knowing the cause are going to fail again. Also at this point of time, we always speak about a patient who is dissatisfied with his TKR. All I can say that if a patient is dissatisfied, he has pain, but all painful knees need not be failed knees. So it is important for us to know the various causes of a painful knee, and then one should keep in mind that these are the various causes because of which a patient can get pain. And you've got to distinguish these patients early on. Some of them will recover, but if you can pick the ones which are going to fail, then you can potentially avoid the disaster. As said, most of the failures, the technical errors occur before 5 years. So the important message which I would like to say is avoid the surgical technique errors, follow a fixed surgical technique and proper cementing, proper closure. This will definitely help you to avoid failures. In case you get a failure, identify it early on. Timely and appropriate measures could probably salvage the joint or help to preserve bone to make it an easy revision. I thank you very much for your attention.